Okay, hello and welcome everybody. Thank you for joining me, Belinda Killian, for the Cyclic Vomiting Syndrome Association's virtual expert presentation, Management of CVS in Adults, a review of the guidelines and novel therapies. I'd like to begin today by asking everyone to remain muted for the duration of this event to avoid disruptions to the presentation for everyone presenting and or watching. There will be a Q&A at the end of the presentation. Please submit your questions to be asked during the Q&A portion in the chat box. Please note that there may not be time for all of the questions submitted due to the number of people that we have joining us today. This presentation is being recorded and will be available at a later time on the CVSA YouTube channel. With that, I'd like to go ahead and get started by introducing today's speaker, CVS expert and CVSA's medical advisor, Dr. Thangam Venkatesan. Dr. Thangam Venkatesan is a professor of medicine in the Division of Gastroenterology and Hepatology at The Ohio State University in Columbus, Ohio, and is director of the Neurogastroenterology and Motility section. The primary focus of her clinical and scientific work is in cyclic vomiting syndrome and the role of cannabis in vomiting disorders. She has published extensively in this field and is the lead author on the first ever guidelines on the management of CVS. She has also published on CHS and cannabis use in CVS. She's involved in multiple key clinical trials and studies in CVS. One of her goals is to elucidate the pathophysiology, I'm going to trip all over that one, of CVS, understand the adverse and beneficial effects of cannabis use in this patient population, and develop better therapies for these debilitating disorders. Now with that, I'll turn it over to Dr. Venkatesan. Thank you so much for your time today, Dr. Venkatesan. Let's get you screen sharing.
Thank you, Belinda, for this introduction. And I'm just going to share my screen here in a minute. Okay. Can everybody see my screen? Okay, sounds good. So thank you again, Belinda, for hosting this webinar. And so I'm going to go over some of the basics, some new information that we have about cyclic vomiting syndrome that we didn't really know about, say, many years ago. So here, my disclosures, and really cyclic vomiting syndrome has been around for a long time. So I do want to say to the CVS sufferers here that this has been around, but it really hasn't gained recognition until more recently. This was actually historically one of the first reports in English on CVS, and this is a physician by name Samuel G., who reported on cyclic vomiting syndrome in about 14 children. And this was one of the first few reports that we really have where he said that they have fitful or recurrent vomiting. And I do want to emphasize here that CVS really affects people of all ages, all backgrounds, all socioeconomic strata. And this is a letter that was written by none other than Charles Darwin. So you're in actually very good company. And he says, 2 days ago, 3 officers of the Beagle came here to dinner. I took every possible precaution, but he was very ill and shaking and violent and could not even say goodbye or attend to his own party. And, there are multiple reports that Charles Darwin had cyclic vomiting syndrome. So why is CVS important? Obviously, you have it, but I think it's important to know the data. In the past, we really didn't know how common it was. It was thought to be a rare disorder, and people thought perhaps it was a pediatric disease alone. And in fact, many adults have continued to suffer with these symptoms because most physicians thought it only occurred in children, and people were given improbable diagnoses. And I'm sure somebody must have told you that you've had a viral gastroenteritis for the 10th time in your life. And now we do know from a very good study that was performed, it was a population-based study, that the prevalence in adults is 2%. So it's really very similar to that in children, as you can see. And just to put that in perspective, I know, there's a lot you hear about other diseases, right? Like Crohn's disease or inflammatory bowel disease and so on. And it's really similar to, say, pediatric inflammatory bowel disease or even celiac disease. So it is really not as rare. In fact, it's quite common. And 2% means that 2 in 100 people have CVS. It is very expensive. The total cost can be very high. And this was a study where we just looked at the impact of CVS on hospitalizations alone. And we looked at something called the NIS. We looked at something called the NIS database. And as you can see here, the total number of CVS patients was around 2,000. And we found that the total cost was around 400 million from just hospitalizations over 2 years. Now, this is a more recent study that we published, and so we, we looked at some insurance claims data, and we wanted to see how much healthcare, what cost the patient due to CVS versus non-CVS patients. So we really looked at the annualized healthcare costs for a CVS patient. So this is these are numbers actually for 1 year. And if you look at this bar diagram on the left, you can see for CVS patients, the average or the mean cost in dollars was around 57,000, but for a non-CVS control, and they were matched. They were actually matched for different comorbidities and other conditions and so on, was around 14,000. So clearly you can see that there is a huge disparity. And I would also like to point out, if you look at the sort of the purple area in this bar, you can see that most of the costs in CVS patients is driven by inpatient care and hospitalizations and so on. The outpatients was a little less definitely than the inpatients. And so this might actually reflect that we need obviously better therapy. We need to keep people out of the ER and out of the hospital, not only just to drive down costs, but obviously to make keep the patient functional. We also looked at what we call indirect impact, right? So regardless of what the cost is, how is the CVS patient sort of suffering? What about short-term absenteeism, days from work lost, and so on? So when you look at this, we looked at CVS patients and non-CVS controls, and as you can see, short-term absenteeism resulted in about 21 days lost from work for the CVS patient versus about a week for non-CVS control. So certainly, again, there is a huge disparity in this. And then if you look at the annualized costs of these patients, you can actually see that there is a difference about $1,500 between a CVS patient and non-CVS controls. And this is actually just extrapolating for work days lost, not due to the direct impact of CVS, but what happens when you don't go to work. And unfortunately, CVS patients, we all know, have very high healthcare utilization. Now, this was actually a much older study. This is almost a little more than 10 years, really 10 years old. And when we actually surveyed our patients, what they told us is that in most instances, a diagnosis was not made in the ED, almost 94% or 95% of the time. And, the ED physicians did not even recognize the diagnosis of CVS. And so really it spoke to a great lack of knowledge about CVS in the medical community, particularly in the emergency rooms. Be as it may, again, this is an old study. And I do believe that things have improved, though I believe that the cannabis and the confusion and so on about cannabinoid hyperemesis has again muddied the waters a little bit. Now, how about impact on quality of life? This was a study we did, and this is something called the SF36. It's a questionnaire that we administer to all patients. And then we looked at different things about physical functioning, about their mental health, about their emotional well-being, and so on, body pain, their just general health, vitality. And as you can see, the CVS patients who really are represented by the red bars have a much poorer quality of life compared to non-CVS controls. Now, I think it's important for patients to understand, not just physicians, but patients to understand how we diagnose CVS. Really, everything is in the history. Unfortunately, at this current juncture, we really do not have biomarkers. So it is not like simply diagnosing, say, hypothyroidism. You just can't go in, get a blood test for the thyroid test and say your TSH is low, and so you might have a thyroid problem. And we rely on a set of clinical criteria. There is an organization called the Rome Foundation, and essentially there are a group of experts who come together and decide what these criteria should be based on the available evidence. And so this is what is called the Rome criteria. And as you can see, there's, really CVS was only introduced in 2006, where we had the Rome 3 criteria. And that was really the first time that they actually acknowledged that CVS was a valid disorder in the adult world. We now have the Rome 4 criteria, and basically it says that you need to have stereotypical episodes. So the episodes, are somewhat the same. It's like a bad movie, the rerun of a bad movie over and over again for the patient. They typically are abrupt in onset. They typically should last less than a week, and they should occur at least a week apart. If you're vomiting every single day, you probably don't have cyclic vomiting, you have chronic vomiting. Be as it may, one of the things I would be careful about is usually what patients with true CVS will actually have an episodic pattern to start off with. But if that goes untreated, over many years, what happens is it develops into a coalescent phase where people are really not able to discern whether they have an actual episode or not, and they're pretty much sick most of the time. People do need to have 3 or more discrete episodes in the prior year, and this really only pertains to adults. And again, I said there should be an absence of really these severe symptoms between episodes, but you can have milder symptoms. Many patients, and particularly adult patients with CVS and children as well, can have, say, chronic nausea or some abdominal pain. And obviously, you should not have any other GI problems or metabolic or CNS problems to explain the vomiting. Patients, say, with brain tumors can vomit intermittently as well because of, the pressure effects on the brain. The center for nausea and vomiting is actually in your brain. So there are so many other things that can cause episodic nausea and vomiting, but we do rely on clinical criteria. Now, I don't want to go over the clinical features. I think you all know a lot. And the reason why I actually put up this slide is this is really an iconic figure. And this was first really kind of observed by David Fleischer, a pediatric gastroenterologist who's done an amazing job over his lifetime. And he noted that, like migraine, there was what we call an interepisodic phase where you're relatively well, and then you have a prodromal phase, and where you can actually abort symptoms. So that's something I think is very, very important for patients and clinicians to understand. And the reason I say this is that this is the time when you can actually take your medications, what we call rescue or abortive medications. So if somebody is in clinic, I might be asking you a lot of leading questions, as in how long does it take, before you vomit? What is the first symptom that you develop? Is it nausea, belly pain, headache, or just, this bad feeling and it's going to come on? And the reason why we want to know that is that if you do have a prodromal phase that you can recognize, the abortive medications can really be more effective. And so once you take those abortive medications, there is a good chance that you can prevent progression to a full-blown CVS episode. And then obviously you have the emetic phase. Unfortunately, if people are in emetic phase, you do take your medications. We do recommend that. But then it's a matter of supportive therapy and just sort of writing it out, if you will. Now, I did have a question from Linda that there are some concerns or questions about the types of CVS. And so there are some types of CVS that have been recognized. One is called catamenial CVS. And catamenial simply means that CVS can occur around your menstrual cycle. And so that means catamenial CVS. Like some people have migraine headaches every time they have their period. I will say that the therapy remains the same. There's really no clear data that, suppressing your period with oral contraceptive pills or other forms of contraception or a depot shot can take away your CVS. So again, that's just something to bear in mind. However, if you do have symptoms that occur around your menstrual period, it might be possible to actually abort this because you know when it's going to happen and you can take your abortive medications ahead of time. There is something called Sato's variant, where it's thought that there is a very high level in a hormone called ACTH, which is sort of produced by the pituitary gland, and patients can have very high blood pressures and so on. This has actually not been very well studied, but however, it is a type of CVS, and many patients can become very hypertensive during episodes. So it doesn't mean that you have what we call essential or primary hypertension. You really want to be careful, because I've seen a lot of patients who get placed on antihypertensives and their blood pressure actually bottoms out when they're okay. So you need to bear that in mind, and you sort of need to be able to tell your doctor, hey, yes, my blood pressure is high, but typically it goes back to normal when I'm out of an episode. And then, obviously cannabinoid hyperemesis is something really that is being talked about a lot. And experts like myself and many other people do believe that it is a variant of CVS, where CVS can be unmasked or made worse by heavy chronic cannabis use. Now, what about hot showers? This is something that patients resort to, and often patients may be dismissed as having cannabinoid hyperemesis because they take hot showers. But I do want to point out here that there are several people who do not take cannabis at all. Nearly about 48% of CVS patients also take very hot showers. And unfortunately, about less than 5% or around 5% can even sustain burns from this. So I would be very careful about doing this. This is something that's very peculiar to this disease, but patients will often get into the bath or into a bath or a shower, and they just keep showering almost the entire day. And, if that makes you better, it's okay, but you want to really be careful that you're not scalded when you're doing that. I don't typically recommend this form of hydrotherapy. Now, what about the management of CVS? I think, with the guidelines, we certainly have managed to, really make it a little more uniform. And in terms of the management of CVS, one of the things I really think this was a very important milestone in the management of adult CVS. We published this, and this was done collaboratively with the American Neurogastroenterology and Motility Society. And with the help of the CVSA, this is what we call an open access journal. So essentially, if you kind of Google my name or Google CVS and guidelines, you should come to this, and anybody can print it off anywhere in the world free of charge. And so this is something that you can actually print and take to your local doctors and local physicians, whoever they may be, and share it so that you can really help kind of spread this knowledge about CVS. And so I won't belabor the guidelines, but essentially this was something based on what we call the grade methodology. We had multiple experts. This was really a lengthy process that we went through. And basically what we do is we divide CVS. Again, we're working on these tools, but right now we try to divide CVS into mild, moderate, and severe. And so we kind of had to pick, some numbers. And when I say that, hey, somebody might have mild CVS, it means that you have maybe less than 4 episodes a year. Your episodes are very brief. They last less than 2 days. You probably recover very quickly from your episodes. And there really no ED visits or hospitalizations, and you're managing okay. And moderate to severe CVS is more than 4 episodes. You have very long episodes. It takes you a long time to recover. And, unfortunately, there are multiple ED visits and or hospitalizations. And this is sort of important to recognize, because we essentially sort of divide patients into these 2 buckets. Obviously, every patient is different, and your treatment plan will be completely individualized. But if you have mild CVS, in general, your physician should give you what is called abortive treatment. So the abortive treatment would include triptans, and typically we try as far as possible to really avoid the oral route. So we would use, say, an intranasal sumatriptan, or we would use subcutaneously. Most commonly, I do use the intranasal sumatriptan. And obviously, ondansetron, I know it doesn't work for everybody, but in some patients, it can really help them. We would use either Phenergan or Compazine or Benadryl. These are things which can make you go to sleep. And typically, this is a cocktail. It works better when it's administered together rather than separately. Now, when somebody has moderate to severe CVS, what we recommend is that in addition to abortive therapy, you also start prophylactic therapy. And prophylaxis, I think most of you know, but prophylaxis means you take the medication every single day to prevent future episodes from happening. And so, if you have to really distill the guidelines, and basically we have 10, really kind of 10 points or 10 actionable items for physicians. And so we made a very strong recommendation that the first line of therapy is amitriptyline. It is the most commonly used medication in prophylaxis of CVS. And even though we don't have what's called randomized controlled trials, where this means that you give somebody a placebo, just something, which is not a medication versus amitriptyline, there was considerable evidence that it really does work. The other medications are alternative medications. Prophylactic medications include topramate. There is I wouldn't say newer, but relatively newer antiemetic medication called aprepitant or Ement. And then there are a few other anti-epileptic medications like zonegran and levetiracetam, though I don't use that as much. Coenzyme Q10 and riboflavin can be used. I do find that sometimes it can help with energy. Obviously, you have to really kind of balance the cost of buying these supplements for long periods of time, because they're typically not covered by insurance, and really you get them over the counter. Now, in terms of abortive therapy, like I said, you use triptans like sumatriptan, and then you use ondansetron. You can use aprepitant for both aborting symptoms as well as prophylaxis. And then finally, it's very important that we screen, or your physician is aware that you can have other comorbid conditions, or you should be aware that perhaps you're not sleeping very well, and maybe that's really triggering your CVS episode. So if you do feel that you have, say, a sleep disorder, then certainly that is something that you really need to seek help for, and hopefully try and make that better. A lot of patients with CVS, about 60% have anxiety and depression. So it's really important that you really treat these conditions, because there's data to show that treating all these conditions can actually improve your overall health. And again, cannabis use, I'm going to talk about that a little bit more. So it's really important that we have a multidisciplinary approach to the management of patients with cyclic vomiting syndrome. Certainly, there are other techniques like meditation, relaxation, and biofeedback, and these are all complementary therapies. And again, it is what we call a biopsychosocial model. So really, the treatment of CVS is just not medication. So yes, you can use medications for CVS, but you really need to treat, say maybe somebody has autonomic dysfunction or anxiety and so on. And I really cannot stress that enough. And avoidance of triggers is very important. I think, certainly for many people, they do recognize that sleep deprivation can really trigger their CVS episodes. Maybe they're not sleeping enough if they have an exam or a deadline or due to work and so on. So I think being a little more diligent about that would help. And then again, the abortive therapy, prophylactic therapy, and, supportive therapy. We discussed this a little bit. Some people do, particularly in children, starvation is a big problem. So try not to skip meals. I usually tell people that they should be having at least 3 meals and 1 or 2 snacks, healthy, obviously. Stress management is very important. Unfortunately, both positive and negative stress. I've had patients who have gone on vacations and they spent their entire vacation in a hotel room. And, so certainly stress management is important. It's very sad when somebody calls from Paris saying, oh my God, they're puking. And so, to avoid all of that, I think really maybe working with a counselor would be important. Chronic marijuana use, I'll talk about a little bit more further down our talk here. And typically in terms of abortive therapy, Again, like I said, triptans are used, and the most common is intranasal. We recommend 20 milligrams intranasally, and you can repeat it in 2 hours. You can use up to 6 times a week. And one of the techniques that I really want to emphasize is some people say, hey, the Imitrex didn't work. The reason it didn't work is most people, when you're squirting something up your nose, you actually go back, and really our neurology friend who was on the guidelines committee taught all of us there's something called a lean forward technique. So you want to lean forward and then you want to squirt it up your nose. That's because by doing that, it actually gets absorbed directly. If you lean back, it actually goes to the back of your throat, and then you just swallow it. So it's really important that it's intranasal and you lean forward. Typically the ondansetron, most people should not give you just an oral pill. An oral disintegrating tablet is good. I know some people use creams, but they don't allow us to compound these things anymore. Certainly granisetron, there was a CVS HOPE trial, and we hope that it can be delivered differently, but that's going to take some time. And then the aprepitant is an oral medication, but it can work, and it is very effective. It is also available in an IV form if you land up in the emergency room, and it is part of my ER treatment plan that I typically give patients. And aprepitant comes as a kit. So it's really because it was primarily approved for chemotherapy-induced nausea and vomiting. And it was not really developed for CVS. So it's not FDA approved for CVS, and it's going to be difficult to do a study. And so because it is not FDA approved, it does have some problems because insurance companies really don't want to approve this medication. Be as it may, when people do not respond to, say, amitriptyline or topamax and so on, or they have other problems or develop side effects, the aprepitant can be given. I sometimes give it daily, but it can also be given on 3 days of the week. So Monday, Wednesday, Friday. Effective in refractory cases, but it is expensive and often denied by insurance companies, which is a bit of a problem. And another thing I do want to emphasize is that you want to take your abortive medications during the prodrome. I know some people have a very short prodrome, or they feel like they don't have enough time before their vomiting starts. But be as it may, take it as early as possible. And one of the studies, and the reason I emphasize this, and I just have this on one single slide, is despite my team saying this over and over again, we often find that people take, say, their sumatriptan, even 4 hours after their symptoms start. And so it becomes really less effective if you allow that much of time to lapse. And we were very surprised that there were actually a large majority of patients who are not taking their medications early enough. Despite instructions. I know a clinic visit can be quite overwhelming with a lot of information thrown at you. But remember that your abortive medications will actually work better if you take it early in the course of your illness. And so again, these are the prophylactic medications. We went over amitriptyline, and then there's something called topiramate, the mitochondrial supplements, and aprepitant. All of these are effective in treating CVS. Now, as far as tricyclic antidepressants, I do want to say, a lot of people feel stigmatized or are a little reluctant because they ask you, what is amitriptyline? And then you have to tell them, obviously, that it's what we call a tricyclic antidepressant. But I do want to emphasize that it's, really not because of its antidepressant properties. We actually use it at different doses that psychiatrists used to use amitriptyline in the past. And I said here onset of action is 6 to 8 weeks. It can actually be a little longer because what happens with amitriptyline is we slowly titrate it. We start at 25 milligrams, we go up by 10 milligrams. If I gave you 100 milligrams, you'd feel like a zombie. And then once you reach the target dose, it can take about 3 weeks before it reaches what we call a steady state concentration in your blood. So essentially, say I gave patient A amitriptyline and now they're on 100 milligrams. After 3 weeks, there's a good chance that every time I draw blood from that patient, the amitriptyline level is going to be the same. So it takes some time to actually build up in your body, if you will. If somebody gives you or prescribes amitriptyline and you feel sick in 2 to 3 weeks, don't feel discouraged, because really, the medication takes some time to work, unfortunately. You do need an EKG at baseline and while titration. And while we really haven't seen a bunch of cardiac arrhythmias and so on, I think it's really important to get it. I often find that sometimes, patients will forget the EKG or they don't have time, but do get your EKG when your physician tells you. And that's very helpful because we can't give you increasing doses unless you get that EKG back to us. And amitriptyline is very effective. It's effective in approximately 80% to 85% of patients. There are about 14% of patients who don't respond to amitriptyline at all. And we found that predictors of non-response in that group were, patients who had a lot of other psychiatric comorbidity, who used marijuana chronically, or who were simply non-compliant. You do have side effects, unfortunately, with amitriptyline. It does occur in about up to 25% of patients. There is daytime sedation, and so you have to take it at night. It does improve over 12 weeks as your brain sort of gets acclimatized. It does improve sleep, though, so it can promote sleep. It does cause some dryness of mouth, and for some people that can be a big challenge, particularly if you have to talk a lot in your job. And we just, there's not a lot we can do about that other than increasing your water intake. Sometimes it can cause constipation. If you do have IBS diarrhea, it might actually also make your IBS better. And so what about Topamax? Topamax is effective. Again, it takes time for Topamax to work. And as you can see, we actually did the study. It was a retrospective study, and the mean number of CVS episodes went from 18 to 6.2. So these were fairly refractory patients. These were patients from my clinic, and I do see sicker patients, but as you can see, there was a significant reduction. And then if you look at the number of ED visits, it went from 4.3 to 1.6, and they cut hospitalizations in half as well. So certainly it does help. Now, what about aprepitant? Again, I said it's a weekly kit. It's very effective. There's no lag time, so it acts very quickly, and that's something that is really very advantageous. And the main problem is the cost and the prior authorization. And I can't tell you how frustrating it is for both physicians and patients. You could try a Merck prescription assistance program. Now, there is a generic form of the EMEND, and so it's a little harder to get through this. But I am trying to work. I just found out I had a childhood friend who works in Merck, and she heard about this story, and she said, "Hey, she's gone on vacation," and she said, "Okay," and she has actually a son with some disabilities, not from CVS, and she said, "Well, I'm going to come back and work on this," and so hopefully she can work her magic with Merck and make things a little easier for our CVS patient population. And some novel therapies, and I have used this in some of my patients with success. There's a little more data actually in the pediatric population. We're trying to get things running. So there's something called the autonomic nervous system. It's very important, and it's your fight or flight response. Now, all of us need that. If we feel threatened, we really need to respond to that threat. And so for some time you need all of that. Your heart rate goes up, your blood pressure, and you're just ready, to take the world on. But at the same time, when that threat goes away, most normal people come back to what we call homeostasis. And in CVS patients, I think there's an imbalance. So it's almost like there's a chronic fight or flight response. So your body is kind of revved up all the time, and really instead of being here, you're kind of here. And so there's some sort of maladaptive response to stress, be it physiological or psychological. And we've done multiple studies to show this. And so this is actually something. Now, vagal neuromodulation, I think there are a lot of devices and so on, but this is actually something that, one of my colleagues, pediatric GI colleagues, has done studies on. And really, so this is something that's non-invasive. You do have to have a physician, though, place it. And so what is generally done, it's just placed over the ear here. And it has been shown to reduce abdominal pain and nausea and so on. And in fact, what they show here is that if you look at this graph, in terms of pain scores and stuff, things actually improved with vagal neurostimulation compared to no vagal neurostimulation. And the improvement was much more significant if you had what is called impaired vagal tone to start off with. So patient selection, I think, is important. And we're hoping in adults to start a study. I was placing it clinically at the medical college, but since I moved to Ohio State, we're still working through some things to be able to place it clinically. But hopefully we'll have an open label trial going soon and measure people's vagal tone and see how this works. And initially we said, hey, we can try this for acute treatment, but that wasn't working. And so essentially this means applying this for 6 weeks. It's a 5-week on, 2-week off. So 2-day off sort of placement. We place it in the year. You can take it off after 5 days, and you have to have this device sort of placed every week. So it is a 6-week program, if you will. And this really seems very encouraging. And like I said, treatment of other disorders is very important. Now I'm going to switch gears a little bit. And I think there are more adult patients here, maybe. And so in terms of, marijuana, obviously it's everywhere now. It's ubiquitous. And every time I have to keep changing the slide because this number keeps increasing. Even as we're talking, it's perhaps one state is legalizing it. And I think what has happened is, it's really outpaced research. And it's a little unfortunate because I think there's a little bit of good and a little bit of bad, and we really need to find the good in it. And this is actually something that was, I shot a picture when I went to visit my sister in Amsterdam, and this was just sitting in a store. This was many, many years ago. They had these cannabis energy drinks, and we really need to figure out, is it good or bad, right? And it's not, I don't mean it to be like a chemistry class, but, you do have different types of cannabinoids. You have something called phytocannabinoids. Endocannabinoids are something we actually produce as humans. So we have marijuana-like substances actually in our body. And, again, cannabis, the two main ingredients in cannabis is THC, which gives people the high. CBD is not psychoactive, so typically will not give you the high. And it acts on what we call 5-HT1A serotonin receptors and not really cannabinoid receptors. But I will say that if you use CBD in very high concentrations, that can also be a problem. And so really this endocannabinoid signaling system, again, is something that's very important, and it helps us. So when somebody is stressed, we actually produce marijuana-like substances, and that helps us sort of cool off, and then we're cool, calm, and collected like we are here. And, there is some data, I've done some studies showing that there are some problems with the endocannabinoid system potentially, and, more research is needed before we find that out. And nowadays, cannabis, it comes in different varieties, shapes, forms. You have brownies, you have cakes. Beware, because there are people who have landed up in the ER taking cannabis-laced cookies without, sort of knowing that there was cannabis in it. I do want to kind of caution people about hash oil, wax, shatter, and stuff. And the reason for that is they have very high doses of THC, the kind of THC that you never saw in a joint, say 20 or 25 years ago. And higher doses of THC actually have opposite effects. So they can produce anxiety, agitation, paranoia. They've been associated with psychosis, and particularly in younger adults. And while they have anti-emetic effects, or, where they can stop vomiting, if you take it chronically and you take very high doses, it can actually cause or lead to vomiting. And again, these are, the cannabis concentrates, and it really has THC levels up to 70%. And this is a problem. And if you dab it and you inhale it, you can actually really administer very large amounts of THC to the body very quickly. In contrast, the THC content in just a joint is around 15%. Compared to 60%. And even the 15% is actually very high. If you go back to the 90s, that was only 3 to 4%. So clearly there is really a difference in the cannabis products that are being marketed and that you as a consumer are taking. And it's important that you know the difference. And, again, I just want to point out that this is, again, related to the percentage of THC in a joint. And if you look here, this is 1995, and this is about 2019, about a couple of years ago. And so here's your, here's your THC. Okay, it's about 3.9%. And then there we go. Keep going up and up and up. And now it's up to 15%. And you can even get 60%. So clearly what people were smoking in the past is very, very different, from what is being marketed to you. So, just beware. And we really need to answer this question. And, what about problems with cannabis? Unfortunately, and many of these studies have shown that there is an increased number of ED visits that they noted once cannabis started getting, legalized. Again, it's unclear whether people just started noticing this pattern of cyclic vomiting because of the cannabis. And but be as it may, there's definitely an increase in ED visits. There's an increase in number of hospitalizations following the liberalization and legalization of cannabis use. CHS, this is a diagnostic criteria. It's pretty much the same. It also says that it may be associated with pathological bathing behavior. So it's very typical. It's exactly the same as CVS, but you need to have really relief of vomiting episodes with sustained cessation. So I want to emphasize the term sustained cessation here, because really in terms of sustained cessation, it doesn't mean anything if you stop it for a week or even 10 days. You really need to be stopping it for 6 months or even a year before you can see what the effects of cannabis use are. And the reason why why I'm saying that is, even if you stop smoking today, it can take up to a month for it to be completely out of your system. It's actually stored in what we call fat cells or adipose tissue. And so that can be a problem. Again, there were multiple case reports and case series. And really, it seemed like, what we call chronic regular cannabis use seems to be the problem. This was a cross-sectional study that I did with my patients, and we actually, use what we call a validated tool. And if you look at this pie chart, most people with CVS at least didn't use cannabis at all. But then there are 22% who use it more than 4 times a week. And I think that's where you start running into problems. If you're using it daily or near daily, that's probably too much. And most patients said it improved their symptoms. These are all patient self-report. And it probably does to some extent, but I think what happens is that just like it makes you feel better for a short period of time, but it actually causes what we call cannabinoid receptor downregulation. And so these symptoms come back faster and faster. And so you sort of almost get hooked onto it. So if you're using it once a month or you're using it once a week, it's different from daily use. And again, we looked at these same patients. Many of them tried stopping it. Typically, they tried it for about a month, but that's not enough. And so I really think that we need longer follow-up. And it is also difficult because obviously many patients, there are perceived benefits from it. And so they are reluctant sometimes to stop it. I will, however, advise you, to stop, because 1, it can stop the stigmatization. And 2, I think we do have, other alternative therapies. Now, this is a systematic review we did. So we took all the cases of, CHS that were published in the literature up to 2018 for about 18 years. And we found that there was not much of a follow-up from these patients. So most patients were not followed up for even 1 month. So it's very difficult to even say whether these patients had CHS or not. So really, I think this is a work in progress, and we'll get to know a little more as we study this problem a little more together. Now, people might ask, why does cannabis cause, or how can it cause hyperemesis, which is an antiemetic? So we do know that, there is a genetic predisposition to it. So it's similar to alcohol. You see, hey, Uncle Joe is drinking like a fish and he's fine. And, somebody else is drinking a little bit more, but they have bad liver cirrhosis and so on. So unfortunately, I think sometimes it's a little bit of luck. It's your genes. And, if you're genetically predisposed to CVS or the side effects of cannabis, that can be a problem. We're looking to see if there's a relative endocannabinoid deficiency. And actually now I have an ongoing study. So if anybody wants to participate, please come to my website where we have simple techniques like even meditation or even exercise for 15 minutes 3 times a week can actually improve your endocannabinoids and can improve things. So we're looking into that. And so I think there's a lot of, debate going on. I think it will go on, and we need more research before we can answer many questions. And, some of Blinda's, so maybe, Blinda did have some questions. So maybe I'll look over this a little briefly, and then I'll take some questions from the audience. So Blinda, she said, these are some frequently asked questions. Hey, Thangam, can you address this? So here goes. I picked 5 and I went with it. So should patients go alone with someone to the first consultation with a specialist? So this is really patient preference, okay? And some people, are not able to tell their story. So certainly if you have somebody who can help with your complicated history, because when you go to your CVS expert or you go to anybody, you've had this for 10 years and your doctor has, 20 minutes with you to distill, 15 years of your illness. And make a plan and understand what you're saying. So if you feel like you need somebody and you want to have somebody, then please do take them along. Should you take notes during the consultation in terms of that? So sorry, and oh yeah, so this was one more thing is, certainly there's a transition from pediatrics to the adult world. I will tell, parents to take a little step back when you come to the adult world. It's going to be a little different. We actually have rules that we can't talk to a parent directly over the telephone, especially our nurses and so on. And so give them a little room, let them start taking charge for themselves, but sure, be there and be supportive. And should you take notes? It's not always necessary. Now, most of the time they should be giving you what we call an after visit summary or patient instructions, which actually gives you in written format everything, that you should be doing for your patient. So take a moment actually before you leave the office and actually look at the after visit summary. Make sure you understand everything. If you don't understand everything, make sure you either tell the medical assistant or the nurse there or the physician, hey, I don't understand this. Can you tell me what this means? And then another question that Blinda posed, how should I prepare for a doctor's appointment, right? So things have changed, and it's just like the airline, we have shortages now, and there are things that go on in the back end that you as a patient might not know. And no matter how much we try, I will say that institutions give doctors limited time, so I myself personally will look at your entire history the previous day to get ready, but how can you be ready? And sometimes we don't have all the records we need. So what I would recommend is that, history is everything, right? So to tell your story, how do you tell your story? Be succinct. But we also want relevant details. So when did your symptoms first start? How frequent are your episodes? How severe are your episodes? Those are things that will determine how I would want to treat you and your treatment plan. Is it impacting your work and social life? Like how many days from school or work have you missed? I don't think you need a lengthy diary, like 365 days, but, I really use just like one piece of, a paper really, and then the ones with the little boxes, and then you just use one line literally with the 30 boxes for 1 month, and then you just check off when you had a CVS episode. If you had a CVS episode day, just put an X on it and then keep an idea. So you can actually have your entire CVS history in one sheet of paper. If you had an ED visit, just say ED visit, ED visit, ED visit. If you have like a whole book, it's going to take me a long time to go through each book. So I don't, while, certainly journaling is a different form of, therapy or keeping accurate account. I think for your doctor's visit, try to be as succinct as possible. So if I see one sheet of paper and I say, oh my God, there are so many X's and so many ED visits, I immediately can tell visually. This is actually something that a school teacher told me. She brought in one of these, just a piece of paper. And it was so easy to keep track of her symptoms. And then she said, hey, 2021 looks like this. And then 2022, I get a blank sheet. The patient's happy, I'm happy. It's like, hey, the medication is working or whatever we're doing is working. The other thing is copies of relevant investigations. Relevant investigations would include, say, an upper endoscopy, if you had a CT scan of the abdomen, if you had a small bowel follow through. Now, some patients come in and they don't know what medications they're taking. So often I'll say, hey, just bring the whole bag of medications, whatever you have tried. Because, when you tell me, hey, I tried some medication, it doesn't work, I don't know what that medication is. And if I don't know what that is, I don't know how to treat you, because I don't want to give you a medication that you've tried and that has been failed, or maybe somebody didn't dose you correctly and we just have to increase the dosage. So before you go to your particular, your CVS doctor, I know it's a little bit of homework, but it'll actually help you in the long run. Write down a list of all the medication, all the non-CVS medications you're taking, the over-the-counter medications, and then what has been tried, when, and why did you stop it? Did you get side effects? Did you just give up? What was the dosage? So those are ways that you can prepare. And then this was another question, what should a patient expect from their doctor? So, obviously a treatment plan, but I think, it depends. You might go to a doctor who's not a CVS expert. And so one of the things that I just typically say is, okay, just your doctor should probably listen. Show empathy, and maybe you don't know, maybe they don't know everything about it. Maybe try to give you a treatment plan. Obviously, a CVS expert will give you a treatment plan. And, if it is your local physician, I think one of the things you want to suss out is this person going to be a partner in your care? They don't need to know everything about CVS. They just need to be able to say, hey, okay, so you're going to see the CVS expert. I'm going to work with them. I'm going to follow their recommendations. I'm going to try to do everything to help you. Because obviously, if you come from California to see me, there's nothing I can do. I just can't wave a wand when you're sitting in California and you're sick. So, your treatment plan needs to be obviously implemented, and you need a local partner. So those are the main things I would really look for. Somebody who's willing and able to collaborate with you. And then, what do doctors expect from their patients? We're very busy, as you know, and as much as I would like to spend maybe an hour, and in the past, I've heard that David Fleischer will spend 3 hours. They'll probably fire a doctor if they spend 3 hours with a patient. But we're very busy now, and unfortunately, there's a lot of administrative work on the back end for us that you don't see as a patient. So be concise. I know sometimes the first visit is a lot. Don't get into tangential discussions, because it's really going to detract from what can be done. Be prepared. Again, there are so many other things other than just medications for CVS. So certainly don't be very defensive if your doctor says, about mental health services. So it's not trying to stigmatize somebody or belittle your CVS symptoms, but these things are all interrelated. And it's not just CVS, it's even Crohn's disease. There's data to show that, people have more flares when they're depressed. So, just kind of be a little open to what is being said. You might not always agree, but, just kind of take it with a pinch of salt if you don't agree, and go and see what happens, and try and, think about it a little bit. And so, again, what can I say? So we're all in it together. And so we work together, patients, obviously the CVSA, the many volunteers who give so much of their time, including, Blinda, be engaged in your care. We want you to be engaged. If somebody comes to us, or mom kind of somehow drags this child and their son or daughter, and then they're just rolling their eyes sitting in a corner, it's not going to work. So you really need to be engaged, follow the treatment plan. There's so much of research that has helped in other diseases, and I said, why not CVS, right? And there's really new drugs in the pipeline. So if you look for any research trials, they may be available on the CVSA website, and so on. So be active, be engaged, be a part of this community, and hopefully we'll ultimately, get there. Sometimes, like this person says, we're not always the one who plants trees knowing they will never sit in their shade, has started to understand the meaning of life. So hopefully, one day all these webinars won't be necessary, and we'll have the perfect fix for CVS. And these are some patient links. Obviously, you're on the CVSA kind of, webinar, so about their link. So do go to their website for, any recent updates and so on. There is another foundation called the IFFGD. Don't try to be Dr. Google. It's okay to actually, it's very important that that you really get sufficient knowledge and information. But I always tell my patients, go to the right source. If you go to the wrong source, you will be freaking out because you will hear all kinds of things that you don't want to hear. I do have a website. You can go to that website, and then there's a lot of information. So again, I want to thank really Blinda for organizing this webinar. And we just managed to take a picture in between a very busy schedule at the ANMS, and there's Blinda there. And that's her son. He has a good kind of selfie arm. So that's a good picture of us. And this is actually my CVS, my clinic manager. I shouldn't say CVS clinic, my clinic manager. She does manage other things too. This is my former team from Milwaukee, but I have moved to Ohio State. So I will stop here. And I know I went a little more than, but I'll take questions. And hopefully I see a lot in the chat, like there are 46.
There's a lot in the chat. If you want to kind of peek at them, I do have one we can kind of start with, and then you can pick any that we may have time for.
Yeah.
You kind of touched on other means of getting medication into the system, because there's creams, patches, suppositories. Like even the Granizatron has a patch, the Sancuso patch. So a lot of that is really kind of talking to your doctor. But do you recommend people talk to their doctors about getting that, or would a pharmacist be more helpful for kind of guiding on what's available?
Yeah, so the availability of some of these things is kind of like I said, in the past there used to be creams, and now in some pharmacies, like even if I want to give, say, a Zofran gel, it's not possible because they've stopped compounding these things just because of all sorts of regulations and restrictions. So I think kind of a bit of both. Talking to both your doctor and your pharmacist, I think would be the way to go. Certainly, like I said, Imitrex is intranasal, and you can also get it as some things you can also get as a patch. And, there are some trials, like I said, going on to see if it can be delivered other ways. So there are a lot of questions that I'm trying to see. There is an echo, people are saying. I'm sorry. Some people have an echo and some people don't seem to have an echo. Yes, Amber says to everyone, I'm glad I'm not alone. And that is true. There are a lot of people who do have CVS. And here's one. So it says my daughter is 16. Her CVS most often affects her early in the morning, and she struggles to get to school before 11 a.m. And if she tries to push herself, she tries vomiting. Has anybody tried PA-free Butterbur root? So I don't know about Butterbur root, but
I do.
know.
They use it a lot in migraines with migraine people. So it is similar to B2 magnesium. They just use it as a supportive medication, but it is a supplement.
Yeah, so I think there is obviously this link with migraine. And, certainly if somebody's struggling to, get up in the morning because of nausea, she probably has inter-episodic symptoms. I would make sure that you optimize that therapy. Is there something you can give her like Zofran or Emend or something to get her to school? If nothing works, I think a lot of my pediatric colleagues will simply ask the school to give them a late start. So that they really don't fall behind with their school. Now there was something about Ativan and Valium, I think. Let's see. We have found Ativan and Valium to be the most effective abortive medication. It is often very restricted. So in terms of Ativan and Valium, yes, it is true. This is an anxiolytic, right? And so what we have found that almost 60-70% of patients with CVS, particularly in the adult world, and probably even in pediatrics, but less so, have what they call panic symptoms. So they are in a state of panic. They hit most of the symptoms for a panic diagnosis. And so clearly Ativan is an anxiolytic. It's going to help you, But again, just like everything else, and we have an opioid crisis, right? So any benzodiazepine has the risk of physical addiction and dependence. Now, it doesn't mean that you never have to use it, but the question is, unfortunately, how often you're using it or how often you need to use it. And unfortunately, the person who has more panic and has more severe episodes and is getting it all the time is probably the person who should restrict use, because you don't want to keep using it every 2 to 3 weeks. And ultimately, it's just going to, you'll have to escalate the doses, and your physician is not going to be kind of comfortable with that, simply because we know that that's just a slippery slope to nowhere. So yes, it can be used certainly in an inpatient setting, but I think you really need to, be careful about that. One more question I'm seeing is, can you be on aprepitant indefinitely? So that's, again, a good question. We don't have so many studies going so far out, right? And, we have looked at this data. It certainly doesn't seem like it's causing any side effects. It's what we call an NK1 receptor antagonist. So in terms of long-term use, we haven't seen any side effects. And if you need it and you're really, really sick, you probably need it. So there's no good answer to that. And I think, again, people participating, and we hope to start a registry. I had people participating in more studies, and really kind of, these ongoing kind of registries and so on. We'll be able to give you more answers as we collect, sort of more data from you, if you will. And so somebody said, diagnosed with chronic nausea, vomiting, do you experience Topamax lowering the heart rate? No. I haven't seen. Bradycardia is not a known side effect of Topamax. Now, having said that, it doesn't mean that it can't occur. But that's not one of the usual side effects. Typically, it is a more cognitive dysfunction. Some people can't think very clearly, and there may be a weight loss of 1 to 2 pounds. The people who are losing weight like it, but so no. So then I think somebody's talking about the length of time or starvation. Yeah, starvation can trigger it. This is strange, but I tend to sneeze twice before CVS nausea begins. Yeah, so people have different symptoms. They have autonomic symptoms, they have nausea. Some people, describe a sulfur burp, so on and so forth. So there's a lot of stuff. Then someone says, my 27-year-old grandson lives with me. He's a chronic weed user. And he self-medicates. He's always sick, jobs at risk, can't find another CVS expert. And then, so I think the problem is this: if your grandson is chronic weed user, you really want to see what this chronic weed is using. So usually what I tell the cannabis users is, they say, people think, hey, it's helping me. I feel like it's helping me. And you're telling me it's not helping me. But then, clearly, this person is on this webinar, and the particular patient is still sick. So my point is, there you have the proof, right? If it's making you feel well and it is completely, it is helping, you shouldn't be this sick. The reason you're this sick is because the marijuana is not working. Even though it makes you feel okay, like even smoking nicotine can make you feel okay for some time, but that doesn't mean it's fixing your problems. In fact, it's probably having the opposite effect, particularly if you're a daily and heavy smoker. And so it really, I think, unfortunately, in this case, I think a little bit of really sort of, what should I say, acceptance and really the willingness to try and come off it would be important. So somebody says, yeah, I was released from the hospital, extremely high blood pressures. Doctor refused Benadryl, which helps the most. Some doctors, yes, they're worried about certain medications and so on. And so no matter what your CVS expert says, I think it can be, problematic. Sometimes I tell people, go and actually chat with the ER person, or, with the doctor or the doctor's nurse, when you're actually well and you're able to articulate and say, look, I'm a normal, human being. And because when people are sick, they're almost, they become sort of, it's very difficult for them to express themselves. And so I think that leads to some communication issues.
Okay,
And
it's
then-
9:04. Dr. V, did you want to have another one, or are you ready to call it?
Yeah, sure. I mean, is there one you want to pick? I'm trying to kind of, I'm sorry, I'm not able to get to everybody's questions.
I know
I'm
there's
trying to-
there's so many, and they're just continuing to come in. There's one that we get a lot that has to talk about medications that people can use when they have a long QT interval. So antiemetics that they can use, because that is a one that comes in quite a lot.
So, aprepitant doesn't cause any prolongation of the QT. So ondansetron can, Zofran can, Reglan can. Yeah, the QT interval is not prolonged with Ement. And if it's an abortive medication, hopefully you can get at least a few.
Okay, and then one more, if you're okay with that? It's probably a quick one. People are asking why sedation helps abort an episode.
Sorry, say that again.
How sedation, or why sedation helps abort an episode?
Yeah, so that's a good question. Many of the sedatives, one, you can't have nausea while you're sleeping. So, it's just not possible. So really sedating somebody, you cut out the nausea. And many of the sedatives are anxiolytic and so on. And so it really cuts down the anxiety, which kind of cuts down, the cycle and so on. So I think that's how the sedation can help.
Wonderful, perfect, thank you. I really appreciate your time today, Dr. V. But that is all the time that we have today. So thank you for your presentation, and thank you everybody for joining us today. I hope you all have a wonderful day.
Yeah, thank you for joining, and sorry I couldn't get to all of your questions. I think somebody's waiting to get admitted, but maybe we'll do this one more time and just do questions.
I know, just need to have just a question one, and it's and just I think it was notated in the chat, everybody, for support calls that CVS has, along with some of the support groups. Great place to ask some of those questions and get support. So yeah, we appreciate everybody joining us today. Thank you so much.
Thank you, Belinda.
Thank you.